All righty. We're going to get this party started here. Hi, everybody. It's Barry Servet, and I'm the medical director for MCPAP. And this is, as you know, our clinical conversations session for the month. Um, and so just some housekeeping things, and I'm going to go ahead and introduce our session and our speaker for today. First of all, just as a reminder, we have our clinical conversations every fourth Tuesday, and so the next topic is December, the fourth Tuesday of December, or the next session. Today is the topic is pediatric depression. And we're going to review our guidelines and talk about any updates to what we know about how to take care of patients with depression these days. And as we said last month, if you were here, this particular year in our program, for clinical conversations, we're going to be kind of going back over some of the fundamentals, in terms of the most common diagnostic groups, just because we have a lot of new primary care providers in our network, and we also just want to keep kind of refreshing, sort of this kind of fundamental base of knowledge. So just a few housekeeping things, and I'll introduce our speaker. That as usual, since last year, we're going to offer CME credits, and this is through Massachusetts General Hospital, and the code is on the screen, as you can see, and so the instructions are the same as usual. Just kind of send that over to the number, but you also have to register with Mass General to be able to claim your credits. We record the sessions, so feel free to just relax and not worry about taking notes, since it'll be available and the slides will be available on the website, www.mcpap.com. We are encouraging, as always, questions. And so enter your questions in the chat. If you want to be unmuted, you can raise your hand, or you can ask in the chat to be able to read it yourself. Otherwise, we'll read your question. Either during the presentation, I'll sort of gently kind of cut in if it's really relevant to what Bruce is or what our speaker is talking about. And if not, we'll save it for the end. And then lastly, we really appreciate getting some feedback. So you'll get sort of a online message about a very short set of questions, so that we can know how you feel about the presentations and what kinds of topics you're interested in for the future. All right, so today we're talking about depression, and we're going to be updating you about our guidelines and best practices and things like that. And our speaker is our own friend and colleague and partner, Dr. Bruce Waslick, and who should be well known to those of you who've been attending this program for a while, because Bruce has done quite a few talks for us. He's a fantastic educator and clinical leader. He's the chief of child psychiatry at Bay State, UMass Chan Medical School, Bay State, and Bay State Health. He is an associate professor of psychiatry at UMass Medical School, board certified in psychiatry and child psychiatry, and he is also in charge of our outpatient services in the division directly, and is the medical director of the Western Central team of our program of MCPAP. He is a local, born and bred in Western Mass, and he attended UMass Amherst for college and went on to medical school at Tufts. He did his general psychiatry and child psychiatry training at Tufts New England Medical Center, and he completed a research fellowship in child psychiatry at Columbia University. He is very well known as a fantastic clinical trials researcher, and he's done some really important clinical trials work in treating depression as the PI of the Columbia site in the famous TADS study, which you'll probably hear a little bit about, but that's one of the sort of really kind of foundational studies that have helped us understand how to treat adolescent depression. And it's kind of an interesting study that had multiple arms and helped to elucidate, sort of how to think about medications and psychotherapy and, how to decide, what route to take in terms of some of those options. So he is a clinical educator at Bay State and has been leading our program and growing our services there, and been doing a fantastic job, and helped to get our child psychiatry fellowship started. And we're just honored to have Bruce as a leader within MCPAP, and we're all grateful for his work in Massachusetts. And so Bruce, I'm going to hand it over to you now, and we'll kind of proceed.
All right. Thank you, Barry, for that nice introduction. It's always such a pleasure to come and join the clinical conversations and do a presentation. Let me share my screen here. I'm hoping everybody's going to be able to see that. Let's see. So I think we're good to go. So I'm really going to make this very practical. This is, I think, the third time we've reviewed the MCPAP clinical guideline for depression since we first rolled out the clinical guidelines back in 2018. There hasn't been a lot of content or change. We've looked at this every year or two, I think, over the past few years, and I think the guideline holds up pretty well over time, which may reflect the robustness of the guideline when we developed it. And a lot of research has gone into pediatric depression over the past few years, but not anything that has really made us consider changing the guideline too much. So I think it's a pretty solid guideline for folks who've never been exposed to the guidelines or this particular guideline. I'm going to do a bit of a general review at the beginning about the guideline project, and then we'll get into the depression guideline algorithm in more detail. So again, a little bit of talk about the whole idea about the clinical guidelines and algorithms, and then we'll talk about the depression. And I hope we have some time at the end for some good questions and discussion of where everybody is at with the clinical guideline. Let's see, I'm hoping this will move. Like mine is stuck here.
Hey Bruce, I have some controls here, so I'll advance the slides for you.
Okay, why don't you do that? That'd be great. So next slide, Barry.
You got it?
No, it didn't change on my screen. That's really weird.
Oh, it changed on mine. That's strange.
How does it look now?
It's on your next slide in my screen, but it seems like it's not showing up on yours.
No, I've got it now. I'm just going to have to click these through individually, but I think we're okay. So this one says MCPAP clinical algorithms of purpose.
Yes.
Yes. All right. So again, the whole idea behind the MCPAP clinical algorithms or guidelines is really to create practical clinical guidelines for primary care providers when dealing with the common mental health problems. And it's really meant to be useful for primary care doctors. We use it to help, primary care doctors have good ideas about what to do when they're confronted with kids with mental health problems in their practice. We also use the guidelines and the algorithms to train our own MCPAP providers to a certain level of consistency related to the kind of advice that folks will receive when they call MCPAP, either for a phone consultation or a face-to-face consultation, either a diagnostic consultation or a psychiatric consultation. So they're meant to be very practical and useful for primary care doctors, and we train our providers to follow them to try to give consistent advice. And again, when we think about the type of situations that primary care doctors are going to be involved with, we're not expecting primary care doctors to be, taking the lead on situations where the psychopathology issues are really complicated, multiple comorbidities, or a lot of treatment resistance. We're thinking more of the mild to moderate cases that are relatively uncomplicated that we think primary care doctors can and are doing a very good job with support from MCPAP. And then, if the primary care folks are dealing with the less complicated situations in primary care, then the specialty care providers will be providing care for the more complicated, the more treatment resistant kids. So that's how we've set up this guideline and most of the guidelines that you'll be seeing as we review these over the next year or two. So the guidelines encompass screening procedure recommendations, how to screen for the particular problem in primary care, some guidelines about evaluation procedures. What do you do in your practice to evaluate a situation when a screening procedure has been recognized as positive? If the evaluation suggests that a kid is dealing with a depressive disorder that we think can be treated in primary care, then we also have some treatment planning considerations. And then we also have some medication treatment guidelines. We're not expecting necessarily that a primary care provider is going to be doing all the treatment, but when medication is an option and important for treatment, we have a set of medication treatment guidelines that primary care doctors can follow for the mild to moderate cases. I'm going to switch to the next slide. All right. So again, to review, the content that we've developed is meant to be most helpful for the primary care and regular primary care practice. We include procedures that can be performed in all the algorithms in the context of regular primary care practice. The content that we've developed recommends the use of standard, well-validated clinical rating scales that can be used in primary care practice. And the content recommends the use of medication guidelines suggesting evidence-supported first-line medication treatments for mental health conditions commonly treated in primary care. Again, these are not going to be recommendations for treatment-resistant cases or kids or cases where we have high degrees of comorbid psychiatric and medical problems. These are much more straightforward guidelines for the relatively straightforward cases. And in this clinical algorithm we're going to talk about today, it's for kids with depressive disorders. Next slide. Okay, in terms of the way we've developed the clinical algorithms, the process of it, that we really developed the content through a clinical consensus process for the MCPAP medical directors leadership team. We've included certain guidelines, and we didn't start completely from scratch. We started with some guidelines for different conditions developed by Heather Walter and her colleagues at Boston Children's Hospital that were originally rolled out and incorporated into the PPOC practices. But then we've modified them and adjusted them to some extent to make them applicable to all of the primary care providers who would be collaborating with their local MCPAP hub. Again, with the idea that they would be useful for all folks as a tool to follow when you're treating, but also hopefully an educational tool at the same time. The first three clinical algorithms we developed were related to depression, anxiety, and ADHD. Next slide. But we've also followed up those first three guidelines that were rolled out in 2018 with guidelines for autism, OCD, PTSD, and our most recent guideline for suicidality. That's going to be uh, more present, I think, over the next year or so. So the process was similar through creating all these algorithms. We didn't start from scratch. We started from algorithms that had some basis, modified them, and incorporated them into clinical guidelines for the MCPAP program. Next slide. Okay, again, when we think about the applications for the algorithms, they're really meant to help train primary care providers in basic evidence-supported tools and procedures for mild to moderate, relatively uncomplicated forms of mental health problems that can reasonably be handled in primary care practice, either with folks doing this on their own or with support, phone consultation support, or face-to-face consultation support from your local MCPAP hub. They're also meant to help MCPAP consulting teams provide consistent training and guidance to you as the primary care providers when we do our phone consultations and our face-to-face consultations across the state. There'll always be some differences, but if you ended up calling somebody in the western part of the state for a consultation for a kid with depression, the type of phone consultation you would get in the western part of the state, we would hope you would get in the eastern part and the central part of the state. So we do want to be consistent with our guidelines. And so we train our providers to the guidelines as well as disseminate the guidelines to the primary care providers in Massachusetts. Again, the algorithms are not going to be the best starting point for the more severely ill, treatment resistant, or highly complicated presentations of mental illness in primary care. And in conjunction with the guideline, we really want providers to feel like they can make liberal use of the MCPAP phone consultation and face-to-face consultations for these cases that you're treating in primary care, or for cases that develop complications, or cases who are not responding to treatment, or the more severely ill presentation. So feel free to make use of the MCPAP program to help at any level when cases are not going the way we hope or that we expect. Next slide. All right, so we'll get into the depression clinical algorithm at this point. It was the first clinical algorithm we rolled out in the clinical algorithm project back in 2018. We're going to look at the guidance for the primary care providers in terms of screening for depressive illness in children and teens, some recommended diagnostic evaluation procedures. We'll talk about different treatment planning considerations, which again are evidence supported at this point. And then for the cases that are going to need medication treatment, some thoughts about initial medication selection and management procedures for the medication component of treatment. Next slide. So this is what the clinical algorithms look like. You know, they're meant to be all on one piece of paper for folks to kind of follow. You don't have to go looking through a long chapter on how to follow the guideline. Let's move to if you can advance the slide, Barry. I think we have different components listed here. But let's go back one. All right, so at the top, we're going to have some ideas about screening and how we conduct screening, including recommendations related to screening instruments. Also, some guidance about what to do if a child screens positive at a well child visit or a sick child visit. They're screening positive for depression. How do we move into a more thorough evaluation? Once we've got an evaluation done, again, at the level of the primary care provider, some thoughts about interventions and treatment choices, depending on what the diagnosis is and the severity of the condition. and then much more specific guidelines related to medication treatment. Medication clearly is an evidence-supported viable option for some kids with depression. Not all kids, but some kids with depression are going to be candidates for medication treatment. So the MCPAP clinical algorithm will give guidance around medication selection, initiation of medication treatment, monitoring medication treatment, both for efficacy and for tolerance of medication, and then some thoughts about longer term processes, monitoring over longer periods of time, and when it might be reasonable to consider a child who has met treatment goals coming off medication. So we'll address all of those things. Next slide. Again, a shout out to Heather Walter and her team at the Department of Psychiatry at Boston Children's Hospital, who developed some of the initial thoughts and ideas around guidelines that were then adapted by the MCPAP leadership team to develop these guidelines that we're disseminating. Next slide. So again, this is the breakdown of the guideline. There's going to be screening and evaluation procedures, help with the clinical decision-making procedures, medication selection support, and then following up and monitoring support over time. Each of the guidelines also, when you access them, you can access these through the MCPAP website, come with a set of what we call clinical pearls, a little bit deeper dive into some of the decision-making related to screening, clinical decision-making, medication support, and then follow-up and monitoring support. We're not going to go into the clinical pearls that we call them, but they're available for a bit deeper dive for folks who are interested in learning more about all of these different processes and procedures. Next slide. So we're going to start with screening and evaluation procedures. And this is going to be, we can consider the modal visit would be a child well visit, not somebody who's coming to attention because somebody is worried about the child developing a mental health problem, but just at a routine screening for a well child visit. And I would say that probably for the primary care providers in Massachusetts, that screening for different types of problems, but including mental health problems is part of the standard well child visit now in Massachusetts. So we're going to screen for behavioral health problems. We have different sort of screening procedures, which could include, a depression-specific procedure or a more general screening tool like the PSC-17, how to recognize a positive screen. And if there is, moving through the screening to evaluation and then treatment decision, figuring out when, intervention is needed, specific mental health treatment such as psychotherapy or medication, or when in less severe cases, more mild cases, more transient symptoms that have been of shorter duration, when we might provide something like guided self-management with follow-up. If we're going to also, as part of the evaluation, we're going to make a determination about a diagnosis as best we can, and also look at different types of situations which we might consider emergent, such as a child presenting not only with depression, but acute suicidal thinking or recent suicidal behavior. And in that situation, we have to escalate the evaluation procedure up to more of a crisis level, getting a trained psychiatric clinician to do a crisis evaluation in that situation to determine whether the child is actually safe to be followed as an outpatient or might need a higher level of care. Throughout all of these processes or procedures, if you're ever running into issues or concerns or questions, again, we invite primary care folks to make liberal use of the MCPAP consultation procedures, both the phone consultation and the face-to-face consultation, whenever you're feeling the need to. Let's move to the next slide. So this is the PSC-17, and this is the screening instrument that I think many people are using once kids are at a certain age, up 7, 8, 9, somewhere around there. The Pediatric Symptom Checklist 17 has items which screen for internalizing disorders. So you can kind of see that item number 2 feels sad, unhappy. Number 6 feels hopeless. Number 9 is down on him or herself. Number 11 seems to be having less fun. 15 is worries a lot. Those are the screening items that we would think of for internalizing disorder. And if we put that subscale together and it's scoring at a 5 or higher, then that would be a positive screen. So we are looking at, again, a subset of items on the PSC-17, which are specifically going to be screening for internalizing symptoms. It also screens for externalizing symptoms and ADHD symptoms with the other items. And so this is often a tool that can help us determine if a child is mainly showing signs of internalizing problems like mood or anxiety problems, or externalizing problems, more like behavior problems or ADHD symptoms, or a combination of both. So it's a very valuable tool. I'm sure that many people are using it in their practices. But when we think about positive screen, we're looking at the PSC-17I subscale of being at a level of 5 or higher. Um, and never on the scale is a 0, sometimes is a 1, and often is a 2. Next slide. All right, so then we are encouraging folks to move from screening to diagnostic evaluation. A positive screen will get us going into diagnostic evaluation. Now, the diagnostic evaluation for a primary care provider is not going to be as comprehensive and as thorough as a psychiatric consultation or the type of consultation that we might get when kids come to see a MCPAP clinician for a face-to-face consultation, or if they're getting an intake at your local mental health clinic. But we want the evaluation to be thorough enough to really get a good diagnostic formulation about what we think is going on, to rule out some of the major concerns, which might tell us that this is not just a mild to moderate case of depression. It might be something more serious, more severe, or much more complicated. So we're going to ask clinicians to, once they get a positive screen, to use their clinical interview skills to find out what's been going on, to do some clinical tracing of symptoms, finding out the level of functional impairments, looking for co-associated medical issues, substance use issues, recent medication treatments that could be involved with onset of depressive symptoms, to do a really thorough medical evaluation and a good evaluation of the primary symptoms. We feel like, in addition to that clinical assessment that folks are going to do, which would also include obviously a physical exam to rule out other obvious signs of medical problems that might be contributing to the clinical picture, to supplement your clinical evaluation with symptom rating scales for the assessment of depression severity. The PSC-17 is not going to tell you how severe the condition is, but we're recommending 2 different scales. One is called the Mood and Feelings Questionnaire, the MFQ, the long version, and that's appropriate for kids between the ages of 8 to 18. Parents can rate this. The youth themselves can rate this. The language is relatively simple and not too complex, so that 8 and above can rate their own rating scale. As you'll see in a second, the authors of the scale themselves don't have a hard and fast cutoff point, but we have set a cutoff point of 27 on the parent-rated form, 29 on the youth-rated form, as being very suspicious of a depressive disorder. Using that as a guideline. For adolescents, you also have the option of using the PHQ-9, the Patient Health Questionnaire 9. It's been pretty well validated for kids ages 12 and above. It's a self-rated scale that kids can fill out. It has a cut point of 10 for moderate illness and then 20 for severe illness. We're going to take a look at both of these questionnaires in the next two slides. As part of the assessment and evaluation, we really want folks to take a look at what we call red flags or diagnostic rule outs that would definitely be expected to affect treatment planning. So the red flags would be, screening for suicidality through either the MFQ, the PHQ-9, or by interview. Looking for signs of psychosis, delusions, paranoia, thought disorder, kids losing touch with reality. That could be a component of a very severe form of depression called major depression with psychotic features. And that will be much more likely to need a specialized psychiatric treatment plan versus somebody who should be treated in primary care. History of severe trauma, especially recent trauma. Make sure we do some evaluation for that, and getting a sense of whether the child is currently affected by substance abuse, because somebody who's having depressive symptoms in the context of a significant substance abuse or substance use disorder might need a very different treatment plan focusing on the substance use, substance abuse, either as a primary or as a component of the overall treatment plan. Can't go into this in too much detail, but in terms of diagnostic rule outs, everybody who presents with depressive symptoms isn't necessarily experiencing depression. So kids who've gone through recent losses or grief can present with signs that look like depression, but is actually normal bereavement. Other kids may have more mild or transient symptoms related to adjustment disorders. Something happened in their life which has really affected their mood. The symptoms are not prolonged or as severe as a major depressive episode, but much more of a reaction to a recent stressor. Bipolar disorder is important to rule out, hard to rule out. I think we get quite a few number of calls from folks where kids are detected to have depressive symptoms, but either in their clinical history or in their family history, there's some symptoms of bipolar disorder, manic episodes, hypomanic episodes. And often clinicians, primary care clinicians, want some either a telephone advice or some face-to-face consultation advice to make sure that the child is not experiencing a depressive episode as a component of a bipolar disorder. People may or may not know, but bipolar depression often requires a very different treatment plan, even a different medication treatment approach than kids who have what are referred to as major depression or unipolar depressive disorders. Again, primary care folks are going to be the experts here in terms of ruling in or ruling out co-associated medical problems, medical disorders, reactions to recently prescribed medications, but also make sure that we screen clinically and even to the point of at times using toxicology screens to make sure that we're not dealing with a child who's presenting with a primary or co-associated substance abuse disorder, because again, that's going to affect the treatment planning. Next slide.
Hey, Bruce, before you move on, I wonder if you could talk a little bit about the clinical interview as part of the evaluation, the diagnostic evaluation. And I was going to just make the point that, a lot of these things, including psychosis and understanding about adjustment, to stressors, bereavement, substance use disorders, a lot of that stuff, comes up, if you take some time, and it doesn't require too much time, but it's a critical piece, at least I think we all believe that after the screen, that there needs to be an interview, a relatively brief interview, but an interview to try to understand what's going on, that sometimes, screening data, turns out not to be clinically significant. Sometimes, just a conversation about, what's on your mind, what kinds of things are going on that have been, upsetting, what's bothering you, sorts of questions, and also to the parents, can sort of give you like a lot of rich information, that can help you sort of contextualize. It certainly doesn't necessarily help, as much as people think about the differential diagnosis, because, you can have all kinds of terrible things going on, and have a major depressive disorder, that needs to be treated, according to our usual, guidelines. But sometimes, it can sort of guide your decision making, actually very often, in terms of knowing how much to lean into psychotherapy versus, how much to emphasize the biological treatment, stuff like that. What are your thoughts about that, Bruce?
No, I agree. I think I think we've talked about in the past, one of the challenges when you're doing a well child visit and you get a positive screen, can you get that rich evaluation dialogue going as part of a well child visit? I mean, you might be able to if there's not a lot of other things going on, but if a kid's got other types of health problems, what might be the best next step would be to say, look, we screened positive on this, but I'd really like to, and we don't have time to do it as part of our well child visit, but I'd like to set up an appointment in the next few days to have you come back, parent, child together and find out a little bit more about what's going on. I mean, if it comes up in the normal well child visit and you've pretty much decided, oh, kids, the patient is feeling more depressed because the grandfather died a month ago. It's a normal bereavement process. You might be able to do something like that in the context of a well child visit. But if you're pressed for time, having that kind of evaluative conversation to really think through what's going on might require a separate visit, So, but I agree, this evaluation process is extremely important in terms of figuring out what's going on and taking the appropriate next steps. And sometimes you end up feeling rushed and you're saying, oh, it's got depression, I'm going to get into this. And then you really haven't done the screens for like the bipolar disorder or the substance abuse or the trauma. And then things get really complicated really quickly. So I agree with you, Barry. I think that the evaluation part of this, is very important, and how folks manage it in the context of their practice is challenging. There's no doubt about it. And I also think it's an area where MCPAP consultants can be helpful if we need, we've got enough information to say, well, we really need a psychiatric consultation or a diagnostic consultation to give us a really good advice moving forward.
Yeah, thanks, Bruce. And I'm so glad that you brought up that point about kind of scheduling an additional visit, because I think that you think about other diseases, that if you identify, a sort of a significant illness, then there are going to be visits that you're not going to be able to take care of all of those things in the well child visit. That oftentimes I think it's normal to want to schedule an additional visit to really focus on that particular illness, and so, yeah, so if you fit it in, to the visit, that's great. If you can't, then it's really important to have the patient back, and then, but either way, that it should include, something that's kind of a conversation, interview, clinical interview, and not just the tools, because the tools can sort of take over. We've seen that in other fields of medicine, where people, forget to do their neurological exam because they know they're going to get a CT or an MRI scan, that kind of stuff, and we sort of omit those things, I think, at our peril in medicine. Okay.
So this is the mood and feelings questionnaire, which we talked about before. So this is going to, again, be your tool for severity. It asks about type of symptoms that have been going on for the past 2 weeks. It's not a lifetime instrument, it's the past 2 weeks. So it's going to give you sort of a snapshot about what's going on at this time. It's you can go through the symptoms individually, but the things I do want to point to is if you look at items 16, 17, 18, and 19, those are really screening for suicidality. If we're going to think about critical items, that might trigger your thinking that the child may be at risk for a suicidal crisis or a suicide attempt, definitely take a look at 16, 17, 18, and 19. because this would be screening for suicidality. Again, the authors don't have a particular cut point, but clinical research has suggested that scores higher than 27 to 29 on this particular uh, instrument are highly suspicious of depression. Next slide. And this is the PHQ-9, again, appropriate for use in adolescents 12 and above, validated. This one is going to screen on number 9 for suicidality as well. The metric here is symptoms present not at all, several days, more than half the days, nearly every days. This is going to ask about symptoms that have been experiencing again in the last 2 weeks. And you can quantitate the scores here with a minimal depression of being 1 to 4, mild depression being 5 to 9, moderate depression 10 to 14, moderately severe depression 15 to 19, and severe depression anything higher than 20. So this can be a good instrument to do an initial assessment and also follow-up as you're moving through treatment. Next slide. Once we've completed the evaluation, then we're going to move into treatment planning and treatment decision making. So in the cases where we're suspicious that there's a problem with depression, but it's at the subclinical to mild level based on our severity assessment, we can do one of the options would be guided self-management with follow-up. There's something going on. I'm worried about you enough to say, we can't just say, well, this is within the normal range of experience, the normal range of functioning. But let's try to get some sleep, try to eat well, try to get involved with activities, maybe do a little bit of immediate problem solving, get some extra help at school, or maybe some work on different sort of interpersonal relationships that are causing stress. But guided self-management, we're going to give you some practical advice, but I do want to see you again in a certain reasonable length of time to make sure that things are better or that things are not getting worse. For the more moderate depression, moderate levels of depression, or in situations where the self-management has really been unsuccessful, I think that's the time when you say, well, we're going to have to think about something clinical here. We need to consider the treatment options that are evidence supported, and those would be either a referral for therapy or consideration of medication treatment or combination of those two. When we get into the range of severe depression, where either the symptom scores are really high, or there's complicated factors, or there's a degree of treatment resistance, that situation is going to be really requiring more of a referral for specialty care for therapy and medication management until stable. Throughout the state, it's sometimes hard to get access to the mental health resources that folks need in a expeditious way. So MCPAP obviously is there to help support folks and help access services if folks cannot get the more specialized services that are called for when we're dealing with more severe forms of depression. But moderate depression, mild to moderate depression, that's where we're hoping that primary care folks will feel comfortable intervening and being a part of the overall treatment team. Next slide. So in terms of medication selection, so in general, you'll hear from for kids who've never been treated with medication before, whether they're seeing a therapist or whether they're not seeing a therapist, medication recommendations are going to start with FDA-approved medications for depression. Despite lots and lots of clinical trials looking at all the different antidepressants over the last 15 to 20 years, we still only have 2 antidepressants that are specifically FDA approved for use with pediatric patients. That is fluoxetine is FDA approved for 8 and above, and escitalopram or Lexapro is FDA approved for 12 and above. So in general, we'll follow FDA recommended guidelines. It's not the only medications that you're going to see being used for depression for kids, but at least in terms of primary care providers, they're very, very good evidence-based, FDA-supported starting places. Other SSRIs can be used, sertraline, citalopram. Um, we don't use paroxetine. The SNRIs, I think some primary care folks have gotten used to prescribing them, but in terms of a basic skill set, knowing how to utilize fluoxetine and escitalopram, I think are a really good starting place. We usually use pretty low doses starting with kids. The younger the kid, the lower the dose we generally start with. So if somebody is less than the age of 12, we're going to recommend fluoxetine starting at a dose of 5 milligrams, 10 if they're 12 and above. Escitalopram, 5 milligrams for 12 and above. Sertraline, anywhere from 12.5 to 25 milligrams as a starting place. And then see how that goes. Make sure the kids are tolerating the medication. Sometimes you see kids respond really dramatically positively in the first week or two. That's evidence supported. We see a lot of clinical response in the first week or two. But we usually think that we're going to go out with a medication treatment for 6 to 8 weeks to see whether kids are going to respond. So a good trial of medication can be up to 8 weeks with consistent utilization at good dosing. If kids are tolerating the medication, we're not seeing much of a response in the first couple of weeks, we'll recommend dose increases, moving up to 10 to 20 milligrams for fluoxetine, 10 to 20 milligrams for escitalopram. The dose range for sertraline is much wider, so usually the lowest therapeutic dose range we think for sertraline is 25 to 50 milligrams. The highest dose range is up to 200 milligrams. Sometimes you have to push up to the higher ranges of dosing in sertraline. But within those guidelines, we try to stay within FDA recommended guidelines. And at the end of 6 to 8 weeks, we're trying to maximize the efficacy of the medication, minimize any problems with side effects, maximize the tolerance. And when we are evaluating kids in follow-up, we're always looking at those two things. Are they tolerating the medicine, and are they showing signs of benefit? I discourage parents from looking day to day, except for the tolerance issues, but really looking over the course of a few weeks. Are things getting better than when we started the medication? And how close are we to the child's baseline as determining sort of a stop point for medication? And of course, these are medications that have the black box warning on them. So we do give parents some general ideas that the medications are safe, but there's a small number of kids who can have really serious negative reactions to the medication, worsening of depression, worsening of suicidal ideation. That's not what we're looking for. We're looking for the opposite. So if parents start to become concerned, or the kids start to become concerned that they're having what's called a paradoxical reaction, actually the symptoms are getting worse instead of better, we encourage the families to call the provider as soon as possible. It gets complicated in terms of decision making, but in most situations where there's any signs of a paradoxical reaction, just on the side of being safe, we recommend coming off the medication and then consider doing other further treatment planning considerations from there. Next slide.
Hey, Bruce, there's a question in the
Yep.
chat. If you have any thoughts as far as the selection, among these particular three medications on our guideline, what are your thoughts about that?
Well, again, under 12, 8 to 12, FDA approval would suggest fluoxetine. 12 and above, either fluoxetine or escitalopram. Fluoxetine has a very long half-life, which in some ways is good because if somebody once they've been on the medicine, they miss a dose, it's not going to appreciably affect their medication level, so they're not going to really have much of a bump. Escitalopram, much shorter half-life, sertraline, shorter half-life. I think for kids with comorbid medical complications like diabetes, I'd almost prefer a shorter half-life medication, because if they have a negative reaction to a long-lasting medication like fluoxetine, it takes longer to clear. So if somebody has diabetes and they get significant appetite decrease and it's going to throw off their insulin regimens and management, or the opposite, severe increase in appetite with a higher caloric intake, I'd probably rather have them on a shorter half-life SSRI than a long half-life SSRI. Um, there are some drug-drug interactions that have to be taken into account because the medications are metabolized somewhat differently. But in general, I think it's reasonable to consider both of these as first line. I would tend to favor fluoxetine for the 8 to 12-year-olds just because it's FDA approved for that age group. All right, and so we're going to monitor, folks. We can reassess severity with the MFQ or the PHQ-9, reflecting any changes from baseline. If kids are getting better, we should see decreasing scores over time. If kids are not getting better, if the scores are not improving or they're getting worse over time, it may be an indication that the kids are not responding to the current treatment plan. That's a good time to call MCPAP for a consultation. Are we in a situation we want to keep going? Maybe some dose
Hey,
adjustments.
Bruce,
Do we want to make a change? Yeah.
there's another question before we start talking about the monitoring and
Yeah.
stuff like one of the audience members asked how can you tell the difference between a paradoxical reaction and natural worsening of the condition?
It's nearly impossible. It's one of those questions it's a hard thing. I mean, really, when I hear that, it's a great question. I'm not trying to minimize the question at all. It's nearly impossible. And so my thinking on that is if there is consideration that the medication is making things worse, and sometimes you can see other sort of medical associated medications which show signs of intolerance, headaches, or appetite changes, fatigue, sleepiness. But if you're left at the end of the day not being sure whether this is progression of illness or worsening due to a paradoxical reaction, I feel like we're kind of forced to take the kids off the medication to try to sort that out. If there's any indication medication's making things worse instead of better, sometimes you have to take the medication off. If you take away the medication and the symptoms get better, less acute, or the suicidality diminishes, then you're kind of nailed down that it's a paradoxical reaction. If things don't get better quickly by coming off the medication, then you're probably in a situation where the condition's getting worse. And those are the type of questions I would want. If I were a primary care practice provider, I would want to discuss those different options with a MCPAP consultant, with a phone consultation, sometimes a formal face-to-face consultation, because it's it's something we've been dealing with now with 20 years since the black box warning came out. What's worsening of depression? What is a negative reaction to medication? And how do we sort that out? And it's a very difficult situation.
Thank you, Bruce. I think I agree. I fully agree with those thoughts. It's such a challenging question. Okay.
All right. So then just in terms of following, so we're going to monitor closely over the first several weeks and then reassess with our scales. And then if we're starting to see treatment response, we're going to keep going with the medication. I usually say if things are much better, the medication seems to be helpful, treatment plan is working, we're going to consider continuation phase of medication, not change the dose, but continue with the medication, make sure the symptoms remain, in response or remission for a prolonged period of time. I like to see 6 months of significant improvement with resumption of functioning, ideally paired with some progress in psychotherapy for the kids who are getting therapy at the same time. No crises, no referral to inpatient units, things like that. If things have significantly improved and kids are in a better place, then thinking about possibly coming off the medication after 6 months of really diminished symptoms and improved functioning. Some folks would go longer than that, but I would say at least having discussions once kids are doing well for a prolonged period of time, being open to it. And I think a lot about timing of medication discontinuation. If kids are really doing well for a long period of time, when do you want to try coming off the medicine? Well, you probably don't want to do it if you're in sort of exam period at school or anything. You might want to wait to summer vacation or a period of time when there's less stress in your life and it'd be less crucial, because there's always the risk coming off the medication for somebody who's had a really good response. Symptoms could recur or they could return. So you have to think that through with families, and also think a little bit about how to deal with things if the symptoms start to recur, even if you're not expecting them.
Hey, Bruce, there's
And
an interesting
yeah,
question, and I actually think that we might need to look back at our guideline document, but the question is about that idea of consulting MCPAP at 4 weeks. If the symptom severity, is sort of not improved or worsening. Um, and I was under the impression that folks, that we guided people around dose titration. Actually, it's the question is whether or not, do they really have to call MCPAP? Can't they just, titrate, towards the max dose, at those intervals, if people aren't getting better. And so what are your thoughts about that?
yeah, I think for folks who have a lot of experience with medication, I think, feeling free to kind of titrate the doses and making decisions on their own. We don't want to inhibit autonomy. For folks who want a little bit more support, about, hey, things aren't going like we planned, and we're at 4 or 5 weeks, the family's getting restless, calling MCPAP and saying, I'm gonna talk to the MCPAP folks for a little bit of support about next steps, and the MCPAP consultant might say, keep going, too early to discontinue, or kid doesn't seem to be tolerating this medication particularly well. Let's maybe think of an alternative. I think it's a judgment call. I think people should use their judgment, but I think we've just put that in there to make sure that folks know that they have access to MCPAP along the way for any types of clinical decision making that is challenging. So I agree. It's not like you would have to call in. It would be more, feel free to call in if you're having any questions or doubts about how things are progressing.
Thank you.
Next slide. So I think to kind of wrap up, the algorithms are not going to be the best starting point for the more severely ill, treatment-resistant, or highly complicated presentations of mental illness in primary care. And like we were just saying, primary care providers encouraged to make liberal use of MCPAP phone consultations and face-to-face consultations for any of the more complicated, severely ill presentations, treatment-resistant presentations, that might not be covered in a MCPAP algorithm. And I think doing this now for 20 years, it just continues to impress me how much primary care folks are doing in their practices, how much work, how much evaluative work, how much treatment work, how far folks are willing to go to provide care in the primary care setting, for even treatment resistant or kids with some level of complexity of severity. So I know primary care folks are called upon to do that. Totally impressed in Western Massachusetts and Central Mass, because we do phone consultations, how much primary care folks care about their kids, care about their kids' mental health. I think the MCPAP clinical guidelines have been really helpful for the low to moderately affected kids, but also I have a great appreciation for how far willing folks are to go, even for the more severely ill kids and the more complex kids in the primary care setting. Next slide.
There is one more question, actually, Bruce.
Okay.
In the last 2 minutes, and I think this is a really good question. It's about Lexapro, escitalopram, and the QTC, just in terms of concerns about the need for monitoring, and the question is really, how big of a concern is Lexapro and QTC, interactions with things like azithromycin, omeprazole, things like that. How much should people be concerned about it? What should people do?
I think people should be concerned about it. Absolutely. I mean, escitalopram is related to citalopram. So the initial concerns about QTC came up with citalopram, and the FDA actually put out a warning, that you really shouldn't be exceeding 40 milligrams of citalopram. Escitalopram is a racemic isomer of citalopram. So, 20 milligrams of escitalopram is relatively equivalent to citalopram 40 milligrams. So, and all of the SSRIs can prolong QTC. I mean, they don't usually do it in a clinically relevant fashion, but when you start adding on other medications that prolong QTC, you have to worry about it. And I think especially with escitalopram, it is a concern. Um, it's listed, all the SSRIs are listed under credible meds as potentially increasing QTC. When you talk to cardiologists, they don't worry that much about them, but I do think you have to give some consideration to it. If you're thinking about going above 20 milligrams of escitalopram, checking an EKG at 20 milligrams, seeing where the QTC is, being very cognizant of other medications that that are giving concomitantly that can also prolong QTC. I don't lose sleep over it, but I'm certainly aware of it, and I will check EKGs and sometimes curbside cardiologists for advice moving forward.
Yeah.
But I would say be cognizant of this, especially when you get to the higher dose ranges of escitalopram.
Yeah. So, and I generally check an EKG. Not every time I prescribe escitalopram, but if I prescribe escitalopram in the higher dose ranges or in the presence of other medications that could increase the QTC, that's when I do it. But I don't do it as kind of a universal screening. Do you, Bruce, or not?
No, it's the same situation. If there's a concomitant medication, and sometimes it's a psychiatric medication that can, like risperidone or another antipsychotic medication that can also prolong QTCs, that's much more specialized care. I wouldn't expect primary care folks to be dealing with those kind of combinations. But other medications that are commonly used in primary care that do prolong QTC, you do have to be aware of it. So I'm in the same situation. I don't do it routinely, but in situations where we're getting to higher doses, or where there's other medications that could prolong the QTC, you start to get synergistic effects. So you do worry about that.
Well, Bruce, we went over time, and I apologize to everybody for that. But this was a fantastic presentation. I really enjoyed it. I learned some things, and I think it was really nice for all the pediatricians and pediatric primary care providers to hear as well. So thanks, everyone. Thank you, Bruce. Thanks, everyone, for attending, and we'll look forward to seeing you at the next session.